Let's see, this one, what do you think?
Like kind of.
Okay. Yeah, so this patient, she's a 65-year-old Caucasian female. She had multiple transfusions. So now they're having difficulty finding suitable blood for her. It's because of the alloantibodies. So this patient after, so excellent, good job. So you find it, so it's an alloantibodies, you're right. So this after the blood is ordered for transfusion, first they test for ABO and RH types, okay? After this, the patient's screened for unexpected antibodies. They call it pre-transfusion antibody screening.
Okay.
Okay, this one is to detect any clinically significant RBC antibodies. So if that negative, patient can be safely transfused. If positive, okay, we need to do further investigation to evaluate the type of antibody, what's going on, why are you attacking with RBC. Okay, and so the major problem that leads to difficulty finding cross-matched blood, especially when patient with the multiple transfusion reaction is alloantibodies. That's patient. Example, patient with sickle cell anemia, myelodysplasia, okay, that's all. Most commonly implicated RBC antigen are E, L, and K. K is a dangerous killer, that's the color. Moreover, these patients tend to develop multiple autoantibodies that make finding compatible blood even more difficult. So that's why. So that's why it's autoantibodies. So this RH and ABO, that's not a big challenge in this patient. Or
Right.
even autoantibodies is less likely to cause problems. Okay. They are commonly causes incompatible cross-match in patients with autoimmune anemia who is taking drug like methyldopa or prekinamide, but not in this patient. How about HLA? What is HLA?
The seronegative.
Yeah, this one is for increased risk for graft rejection.
Oh, graft
Yeah,
rejection.
patient who's waiting organ or bone marrow transplantation.
Oh, okay.
Okay. So RBC do not express HLA antigen, so you just make sure you know that. That's why it doesn't have rejection to RBC. So that's another thing.
Okay. Let me get problem reviews. I'm not
Okay,
sure.
so that's, yeah, so this is very interesting case. So the risk factor for coronary artery disease, we have two types. The one that we call the coronary heart disease risk equivalent, which means exactly like having coronary heart disease. And the other one that lower risk factors, like established coronary. The one that is highest risk factors is three. Number one, non-coronary atherosclerotic disease, like in carotid, peripheral artery, abdominal aortic aneurysm. Number one. The second one, diabetes. Third one, chronic kidney disease. Those are. While the less risk factors is not that strong, we have the age more than 50 in men and menopause in women. Male gender, family history of coronary artery disease in a first degree relative less than 50 in men and less than 60 in women. That's considered risk factor. Hypertension, it's a lower risk factor.
Lower.
Dyslipidemia, also a risk factor. Cigarette smoking, obesity, those risk factors. So out of all these, the highest risk factor is what? Diabetes.
Diabetes. Okay.
Gender is a lower tier of risk factors. Hypertension is an established risk factor, not a major risk factor. So guidelines recommend less than 140, should be fine. But in diabetic, they recommend less than 130 blood pressure. And
Yes.
people with nephropathy with a proteinuria more than 500 milligram, they recommend to be less than 130. Okay. Let's see what else. Alcohol consumption. Alcohol protective actually for coronary artery disease, they say. Women generally lower risk factor than men. Okay, so that's the age actually, yeah, that increases. It has a risk factor even though he's a 38, but even if he was 60, still diabetes is stronger.
Okay.
Okay,
Oh.
so this patient is a very interesting case. The main clue, she's 16-month-old girl. She eats a lot of cow milk. That's the main thing. So RB red cell distribution limit is within normal limit. RBD red blood cell distribution width within normal limit. MCV low. What is that? This is thalassemia. But if I show you the red blood cell distribution width increased, now what's your diagnosis? That's all that you need to know. That's just two informations. That's all.
Iron deficiency?
Excellent. It is iron deficiency anemia. You treat them with just iron. Okay. So there are risk factors for iron deficiency anemia: prematurity, lead exposure, and in age less than 1, delayed introduction of solids. Like if there's exclusive breastfeeding after 6 months, that's increased risk for iron deficiency anemia. Caused soy or goat's milk, that's also increased. But if age more than 1 year, then more than 24 ounces of cow milk, that's a risk factor for iron deficiency anemia. And less than 3 servings of a day of iron-rich food, also a risk factor for iron deficiency anemia. Okay?
Yes.
So that's the thing. Alpha thalassemia, they have HBB part on electrophoresis, which is not seen in this patient. Look at the electrophoresis, HBS and HBA. Anemia or chronic disease causes normocytic, normochromic anemia. So the MCV will be normal, and rheumatoid and renal failure. Beta thalassemia, as we said, they have normal red cell distribution width. Okay, and also they don't have HPS on electrophoresis.
Right.
Okay.
Yeah.
And HBSC disease is a less severe variant of sickle cell, characterized by mild normocytic anemia, and hemoglobin electrophoresis shows equal amount of HBS and HBC. They not like HBS and HBA. Okay. So anyway, this patient have sickle cell trait because HBS, HBA, and iron deficiency anemia due to cow milk mostly. Okay. So I like this case, this patient. It's very important case. He's a 60-year-old guy who on chest X-ray. That's all what you need to know. You see, that's why I didn't bring the whole case. So hypoinflation. That's what you need to know. The PCO2 is 58. That's what you want to know. Okay.
Okay.
And PO2 is 170. So what does that tell you? When I tell you the PCO2 is 58.
That he is
After surgery, he just had the surgery. What's the cause of that? So that's why. Which one of these? What do you think? Okay, so that's the main clue for this patient. He's having the PaCO2 is 58 and hypoinflation. Respiratory rate is 7 immediately after surgery. So what is the cause of that? Most likely residual anesthetic effect. That's what causes PaCO2 is 58. So while upper airway edema most likely is a complication of endotracheal intubation and present in the early post-operative period. But the presentation, they will have stridor, tachypnea, and increased work of breathing rather than somnolence and bradypnea like in this patient. So they have increased respiratory rate, so that's not good. So Yeah.
I was thinking of that's why I asked you vitals, because I thought if it was residual anesthesia effect, wouldn't he have hypotension too, or?
No, blood pressure was normal,
Oh.
125. So respiratory, would give it to. So pulmonary. So that's the thing. Pulmonary embolism. It happened 3 days after surgery.
Uh-huh.
That's most likely. They have elevated AA gradient due to perfusion defect and present with sudden pleuritic chest pain, and you don't have respiratory rate 7. That's the
Mm-hmm.
difference. Bronchospasm is cause of early post-operative hypoxemia
Mm-hmm.
and causes wheezing on chest X-ray and the physical exam. This patient doesn't have any wheezing on chest lung exam. That's why it's
Okay.
none. So atelectasis, it's a common cause of post-operative hypoxemia, but usually occur 2 to 5 days after surgery. It's uncommon to occur immediately after surgery, so that's a big clue.
Oh, okay.
Okay. So in addition, atelectasis causes hypoxemia due to intrapulmonary shunting.
Mm-hmm.
That's why if hypoxemia failed to correct with supplemental oxygen, and the AA gradient is usually high. They have very high AA gradient. So we have common complications. So I'm going to give you the symptoms and you tell me what are the name of complications. So
Mm-hmm.
immediate post-operative, immediately present with stridor and due to endotracheal intubation or pharyngeal muscle laxity. What is that?
Airway edema.
It's not upper airway edema. Then there's another one immediately after surgery. He's taking anesthetic, benzodiazepine or opiate, and they have decreased respiratory rate or tidal volume. That's the main clue. What is that?
That's the like a anaphylactic shock to the anesthesia.
No, that's a residual anesthetic effect.
Oh, residual.
Because decreased respiratory. How about if
Okay.
you have wheezing early postoperative? What is that?
Bronchospasm.
Bronchospasm. How about if we have fever, elevated white PC, purine and secretion, and filtrate on chest X-ray 1 to 5 days after surgery? What is that?
Atelectasis.
This is fever.
Oh, fever.
It's purine and secretion. So this is pneumonia.
Pneumonia. Yeah.
How about 2 to 5 days after surgery? Mostly thoracoabdominal surgery. And they present with splinting, reduced cough, retained secretions. What is that?
Atelectasis.
Excellent atelectasis. How about patient after 3 days present with chest pain, tachycardia, little improvement on supplemental oxygen? What is that?
Pulmonary embolism.
Yeah, pulmonary embolism or thromboembolic path. Okay. So let's take 2 minute break and we'll go over our usual, like I'll throw out cases on you, okay?
Okay, thank you. Yeah.